Welcome to AETCM, the emergency medicine channel. Today let us discuss about one important clinical problem in emergency room, that is vertigo. We may use vertigo for dizziness, dizziness for vertigo. So many terms are interrelated to vertigo. Giddiness, dizziness, vertigo. But true vertigo is always, when we ask the leading question to the patient, they will tell that surroundings are spinning or moving around the patient. You can see here the picture. The surrounding is spinning around the patient, not the patient head is having heaviness, dizziness, patient head is rotating. That type of feelings are not there in true vertigo. It's a type of rotational motion sensation around the patient. The surrounding, that is a room, fan, bed, everything is moving around the patient. But whereas in hypertension or postural hypotension or complete heart block, in that type of condition, patient normally tells that they have a heaviness of head is rotating. Like that feeling will be different from true vertigo. Here the surroundings are spinning around the patient. So we have to always differentiate vertigo from dizziness, lightheadedness, syncope, pre-syncope, seizures, and other conditions like headaches, like vascular headaches also can have similar findings. So when we talk about vertigo, it is classically divided into central vertigo and peripheral vertigo. Central vertigo can be due to the problem inside the ear. Central vertigo can be due to the problem in the brainstem or cerebellum. Peripheral vertigo is due to the problem inside the ear. So there are two or three important causes for peripheral vertigo. One is benign paroxysmal positional vertigo. Depending on the position, patient develops vertigo. Other one is Meniere's disease. Patient develops vertigo, tinnitus and hearing loss. Other important conditions are acute labyrinthitis and vestibular neuronitis. Both these conditions are due to acute viral infection. They can have a preceding viral illness like sore throat, cough and giddiness, dizziness, all these things. Another important condition is herpes zoster oticus or Ramsay-Hunt syndrome. That is a rare condition. Here patient can have skin lesions over the ear and pinna. Central vertigo is mostly due to acute central vertigo is mainly due to stroke. Posterior circulation stroke is the classical cause for central vertigo. Other conditions like tumors, CP angle tumors, like brainstem glioma, medulloblastoma, vestibular schwannoma, all these things. There are other conditions like multiple sclerosis. They all can produce central vertigo, but the classical condition in emergency room they present with vertigo is posterior circulation stroke. So it is very important to identify and diagnose posterior circulation stroke from other types of peripheral vertigo, because if you think that if you misdiagnose a central vertigo as peripheral vertigo, then the problem created by this stroke can be severe, because posterior circulation stroke is more complicated than anterior circulation stroke. They can have complications like raised ICP, corning. All these things are very common in posterior circulation stroke than anterior circulation stroke. So you can differentiate central vertigo and peripheral vertigo. Positional adaptation seen in peripheral vertigo, depending on the head position or body position, vertigo can increase or decrease. That is not seen in central. Nystagmus only during attacks, only to the position in peripheral vertigo, but that is not the way in central vertigo. It is always present. Fast component of nystagmus always from affected side, fast component of nystagmus towards the affected side in central vertigo. Deafness, tinnitus is seen in peripheral vertigo. That is not seen in central vertigo, but we cannot tell that. Sometimes these things like deafness or tinnitus can be seen when there is a root of 8th cranial nerve involved in the central vertigo also. You can, like tumors, you can get that. Other neurological signs are seen in central vertigo because it is in the pons or midbrain or that area. The lesion is in the brain stem. So other neurological signs also can be there in central vertigo. Now, when we talk about nystagmus, it's a rhythmic, jerky, involuntary movement of eyeball when the eyes are fixed on an object. There are two phases, fast and slow phases. Fast component determines the direction or side of the nystagmus. Nystagmus direction is usually described in terms of fast phase and may be horizontal or vertical. Now, okay, so that is very important. Whenever the patient who is having vertigo coming to emergency room, we have to always examine for the nystagmus. Nystagmus can be seen in both central vertigo and peripheral vertigo, but we can see some differentiating features for this. There are different types of nystagmus. We are not going to that types of nystagmus here. So horizontal, vertical, rotatory movements can be there in nystagmus, or pendular movement can be there in nystagmus. Some nystagmoid jerks are seen in normal person. That is not nystagmus. When the eyes are tested in extreme deviation, these jerks are seen. And there are other types of nystagmus also seen in various type of neurological disorders. I am not going to the details of that now. Now, when we have a nystagmus, we have to see whether it's a central nystagmus or peripheral nystagmus. That is also very important. Direction of nystagmus, fast phase opposite to the lesion, fast phase towards the lesion in central nystagmus. Type of nystagmus, it is rotatory or horizontal in the peripheral nystagmus, horizontal in cerebellar lesion, vertical in brainstem lesions in central nystagmus. Visual fixation inhibits nystagmus. No visual fixation can inhibit nystagmus in central nystagmus. Head movement increases nystagmus. That positional change is there. No positional change. Association, vertigo, tinnitus can be there in peripheral nystagmus. Other neurological findings can be there in central nystagmus. Causes, Meniere's disease, vestibular neuronitis, vascular disorders of 8th cranial nerves, benign positional vertigo. Other conditions like stroke, demyelination, Wernicke's encephalopathy, alcohol intoxication, all are seen in central nystagmus. Now, benign positional vertigo means whenever patient's position is changing, only in some positions patient can have nystagmus or vertigo. Like a patient who is having right-sided ear problem, only patient is lying down towards the right side or bending the head towards right side, patient can have nystagmus, vertigo and vomiting and all. So that is positional nystagmus, and it occurs suddenly. That's why it is called as paroxysmal. It is a result of otoconia, tiny crystals of calcium carbonate that are normal part of the inner ear anatomy. They detach from the otolith membrane in the utricle and collecting in one of the semicircular canals. When head is in standing position or in the same position, gravity causes otoconia to clump and settle. When head moves one side, otoconia shift. This stimulates the cupula to send false signals to the brain and produces vertigo, nystagmus, all these things. So it's a problem inside the ear. So otoconia is displaced, and that displaced otoconia moves inside the ear and produces all imbalances. You can see the figure here. That is benign paroxysmal positional vertigo. So you have to examine the patient in right lateral position, left lateral position, head down position, all position you have to examine. Only during some position patient develops giddiness or vertigo. Nylon-Barney test is or Halping's test. It can be done in patients who is having vertigo and Bppv. It's a test for Bppv. You can test the patient, make the patient sit, turn the head to one side, suddenly make the patient lie down. Head should be in turned position itself, but it will go down off the table. So patient develops nystagmus on one side. That means that side is the problematic side. Now another maneuver, that is Epiley's maneuver. with Epilev's maneuver, you can treat the patient. Actually, the treatment of benign positional vertigo is repeatedly doing this maneuver and dislodge that otolith from the semicircular canal. So that helps the patient to relieve the symptoms of vertigo in benign paroxysmal positional vertigo. Meniere's disease occurs in elderly individuals. That is a classical difference between other types of vertigo to Meniere's disease, and they can have hearing loss also. Vertigo, tinnitus and hearing loss. Tinnitus can be seen in many drugs also. We should remember that it can be seen in quinine, aspirin overdose. Many other drugs also can produce tinnitus. But vertigo, tinnitus and progressive hearing loss. So the third part is very important. Progressive hearing loss is seen in Meniere's disease. Labyrinthitis, mostly it is due to the inflammation of membranous labyrinth. It is mainly due to some infections, mainly viral infection or some bacterial infection also can produce this. Now, whenever we have a patient who is having vertigo, nystagmus, giddiness, posterior circulation stroke suspicion, you have to always take MRI, because vertigo due to a peripheral problem like acute labyrinthitis or labyrinthine neuronitis, that is not a serious issue. But if you don't examine the patient properly, you can miss posterior circulation stroke, and it is very dangerous when we comparing with a anterior circulation stroke. A small anterior circulation stroke will only produce some minimal neurological deficits. It will never produce a raised ICP or coning. But whereas posterior circulation stroke, it is in a small area, it's a small compartment, closed compartment. So any small lesion can produce severe pressure effects. So we have to be very careful. So these patients also can have vertigo, dizziness, and they also have neurological findings. Some neurological findings may be associated with vertigo or giddiness. So if you examine properly, you can get the diagnosis, and we may have to take an MRI, not CT scan, because CT scan will not pick up posterior circulation lesions properly. So we need to take an MRI. MRI can pick up posterior circulation stroke, posterior circulation tumors, posterior cranial fossa tumors, demyelination, everything can be picked up by MRI. So do not try to take CT scan in this type of patients. If possible, go for MRI only, otherwise you may miss the diagnosis. Now once you understand that it's a peripheral nystagmus, then you can use the drugs like beta-histine or prochlorperazine. All these things can be tried. But if you are giving this type of drugs in a posterior circulation stroke or other problem, you may miss the diagnosis. Some patients may transiently improve these drugs and you may miss the diagnosis also. So you have to be very careful, confirm the diagnosis, then only use these drugs. In that, most important drug is beta-histine. Beta-histine 8 mg tablets are available. You can give 16 mg 3 times, like 2 tablets 3 times daily, and patient can take it with meals. Maintenance doses generally in range of 24 to 48 mg per daily. So you give 16 mg 3 times 1 or 2 days. Once the patient improves, reduce the dose. Some patients may require 8 mg TID for many years, because Meniere's disease and all, patient may not improve at all. They may slowly deteriorate. So you'll have to give for many years. There is no much side effect for this drug. You can safely use this drug for many years. Much of the side effects are not described in classical textbooks, or patients are not complaining about the side effects even after using it for many years. But textbooks says a lot of side effects like antihistamines. So we have to monitor the patient. Another important drug is, you know that we give injection Stemetil in emergency room, prochlorperazine, that can be given as 25 mg as an initial dose. Then you can switch to oral tablets. 75 to 100 milligram daily can be given. But continuous therapy is not advised with this drug. We give beta histine tablets for continuous therapy, but initially in emergency room this can be tried. Physiotherapy, that is Epley's maneuver training, either the physiotherapist can do or ENT person can do this and train the patient for this. This has to be done repeatedly so that patient improves clinically. So we have discussed about one important clinical problem, that is vertigo. Vertigo can be due to a peripheral labyrinthine problem. It's a benign condition, whereas it can be due to a serious condition like posterior circulation stroke. So the clinical examination in emergency room is very, very important for vertigo. We have to identify which is peripheral, which is central. We have to always look for nystagmus. Many times nystagmus is not very visible in emergency room when we are practicing very fast. You can even use a torchlight to diagnose nystagmus. Like when you are using your finger like this, moving that side, this side, you can see nystagmus. Instead of this finger, if you use a torchlight and which is moving around your eyes, you can see the movement of eye very clearly in that torchlight. If there is good sunlight available in your ear, that is also very good. But if lightings are not very good in your area, you have to use a torchlight instead of your finger, which detects the nystagmus. And torchlight can detect nystagmus better than a simple finger movement test. Thank you.